Hello, and thank you for joining us here at ECR. My name is Dr. Christopher Austin, and I am really excited to host this session entitled Building Back Better, Safely Accelerating AI Adoption to Deliver Sustainable Breast Screening Programs in a Post-COVID World. I'm a UK-trained radiologist, now based in the rainy coffee capital and global tech hub of Seattle, Washington. I've been with Chiron for almost 3 years, where I serve as Chief Medical Officer. Today, I'm delighted to be joined by two experts, Frans van Beers, who leads business development for us here at Chiron. Frans is going to share his analysis of the impact of COVID-19 on breast cancer screening. And Dr. Nisha Sharma, the Director of Breast Screening and Clinical Lead for Breast Imaging with the Leeds Teaching Hospitals NHS Trust. Nisha will discuss how the pandemic affected their breast screening program, how it exacerbated the need for clinically safe AI, and importantly, the results of their clinical study that evaluated an artificial intelligence solution as an independent reader in a double reading workflow. With that, I want to give a little bit of context to set the stage for our presentations. I think we're all painfully aware that COVID-19 has had a profound impact on breast cancer screening services in the UK and across Europe. Even before the pandemic, screening programs suffered from radiologist shortages. But the closure of screening programs and a fall in the number of women attending their appointments has further exacerbated the situation to crisis levels in many countries. Across the UK and Europe, millions of women have missed a screening round due to COVID. Estimates suggest that in the UK alone, 1 million women may have been affected. So it's clear that screening providers need to adopt a new approach to deal with the number of unscreened women. And they also need to build back better to address the workforce crisis and ensure the sustainability of breast cancer screening programs. Many providers are turning to AI as a possible solution, but how can they ensure that they are able to deploy at pace while maintaining patient safety? We'll discuss the core question during our live panel discussion following the two presentations. We'll also have a Q&A with our experts, and at any point during the symposium, you can enter your questions into the Slido live chat box on your screen. During our Q&A session, we will certainly try to answer as many questions as we can, but if we don't get to yours, we would be happy to follow up with you afterwards. So at this time, I'd like to turn over to our first presenter, Frans van Beers, who is based in the Netherlands.
Hello. My name is Frans van Beers and I'm responsible for business development at Chiron Medical Technologies. Unfortunately, we are still unable to meet in person, but I'm happy to be with you virtually today and walk you through an analysis on the impact that the COVID-19 pandemic has on breast cancer screening programs. COVID-19 has heavily impacted breast screening services around the world. In many countries, services have been suspended and are, as we speak, still not back at pre-pandemic levels. Although extra safety measures for participants are being put in place to allow services to reopen, many are only able to operate at 60 to 70% of their pre-pandemic performance, which is causing a huge group of eligible women to miss their planned screening round. Immediately after the first lockdown period, many organizations in Europe, as you can see on the screen, started publishing alarming messages. And as time went on, the true impact of COVID on screening services was becoming clearer. In September last year, the Breast Cancer Now organization in London, for example, reported that almost 1 million women in the UK only had missed vital breast screening. This huge backlog could mean that 8.6 thousand cases of breast cancer could be missed. Now, after a second lockdown in many EU countries, the impact is expected to be even higher. And the concern is not only about the increasing number of women that have missed their screening round. It is also about a fall in the number of diagnosed breast cancers and the impact on quality of life during the delayed treatment. Extra attention needs to be paid now to re-engage with the women and make them aware that they need to book an appointment. Clear communication of what and how is key to fight the number of unscreened women. New information around having a mammogram while being recently vaccinated should also be communicated with great care to avoid women choosing not to participate. And in the last quarter of 2020, studies also outlined that extra breast cancer death could be expected due to the delayed screening. Whereas just over a year ago, the challenge for most of the screening programs was to find an answer to the radiologist shortage. how to deliver consistent quality in reading to filter out the variability in reading performance, and how to shorten the turnaround time of the results communicated to the women that participated in the screening, it is now clear that COVID-19 is actually having an impact on the total pathway of breast screening, from screening to treatment, and that there are many more challenges ahead. Those go all the way from reduced access to screening on the left of this slide to the potential increases of later stage diagnosis, and with that, less treatment options, potentially leading to an increased mortality over time. The main challenge screening programs are currently facing is not a limited capacity in reading the studies, but a limited capacity for image acquisition due to the newly introduced safety measures to fight COVID and having women participate in the screening round. As an example for showing the impact of COVID on breast cancer screening programs, I have selected the UK breast screening program. But what applies for the UK applies also for many other countries in Europe. To calculate the impact caused by the pandemic, we took the number of eligible women that participated in 2019 and calculated the normal and maximal screening capacity. The Public Health England Screening Committee members shared us the information about the uptake during the pandemic, the dates that the services were closed, and also the percentage of services that became available during the COVID period, as well as the time that is required to carry out each screening. And with this data, we have calculated the number of unscreened women and also looked at the different scenarios to increase uptake and acquisition for the screening program. For the UK breast screening program, the figures look as follows. The normal number of women annually participate in the screening is around 1.8 million out of the 2.6 million women that are invited for the screening. As per the information from PHE, the maximum breast screening capacity is designed to perform 2.6 million screening mammograms annually, and the current annual volume of studies that needs to be read is 1.8 million. As we have learned from many breast services, this 1.8 million studies to be read is already at the edge of the reading capacity for both radiologists and radiographers that perform reading tasks. As the model outlines in the light green cells, the number of women that have been able to attend their screening round in the past year is 978,000 women. The number of women who did not have their screening mammogram is 815,000. Consider that the UK has been one of the most heavily impacted countries in Europe by COVID. They have done a great job to achieve these numbers. As can be seen in the third column in this table, the screening service adjusted the invitation policy to an open invite to maximize the number of screening slots per screening unit per day and give the women a chance, a wider choice, and a chance to participate from October onwards in their screening program. As mentioned earlier, the challenge now is shifted from staff shortage to the acquisition of image. And that brings us to the current question that many services have, not only those in the UK. How to increase the number of image acquisitions whilst offering a safe environment that is in line with all the prevention measures for COVID-19. In the model, I looked at different options. Changing the invitation policy, longer daily opening hours, open on, for example, a Saturday, bring radiographers back to the acquisition side of their job and temporarily stopping the reading tasks, and finally introducing on a temporary basis additional screening equipment at the sites. All of these measures contribute to fight the number of unscreened women and bring back the program in line with the 36-month interval in the UK. I will now show you the impact of two of these measures, changing the invitation policy and adding an extra opening day. As shown in the previous table, by the end of September, the invitation policy was changed. More invites were sent out to women and they were given the opportunity to opt in for a mammogram at an available open slot. If the policy would have remained unchanged, the number of unscreened women would have been far over 1 million, whereas it is now at 815,000. Taking the courage to implement this change during COVID has already helped over 254,000 women to get their mammogram, whilst using the existing capacity and having all the COVID-19 safety measures in place at the screening units. But although the first step of catching up on the unscreened women is made, more is needed. Here I show in the model the result of combining both the open invitation and adding extra capacity to the screening by extending the service with 1 extra day per week, adding up to 48 days per year, while also taking the longer screening time per woman into account due to the COVID measures. The model is based on the expectation that by October 2021, the situation is back to normal and the full capacity can be used. Implementing those measures so that the screened women will grow to 2,245,000 in the yellow cell at the right of the table for the coming year, and that the number of delayed screened women decreases with almost 500,000 to 365,000. The conclusion is easy to draw. If the capacity will be further extended, let's assume adding also a Sunday to the screening, then even within the next year, all delayed women will be screened. But if this is realistic from a staffing perspective, has to be investigated. Another conclusion from the outcome is, and that's very visible, the number of women screened in the next year is almost 450,000 more than the normal average of 1.8 million in 2019. And this now is bringing us back to at least one of the initial challenges the breast cancer screening services were facing, the shortage of staff. So the next question is how to avoid the bottleneck caused by shortage of staff. The bottleneck is caused by the acquisition of mammograms from unscreened women. But on top of this, the other reason the bottleneck becomes visible is because of the radiologists being already thin spread within the breast cancer screening service and the expected retirements. As published in both the Royal College of Radiologists report and in the report of Public Health England, the retirement among breast radiologists is around 26 to 32% in the coming years. As shown in the model, catching up with the unscreened women will increase an extra 450,000 studies, or 25% more than the normal annual 1.8 million studies as performed in 2019. Adding a second additional day to the screening service and opening 7 days a week will also cause issues like variability in reading and will potentially also lead to increased fatigue and burnout for radiologists. So how can we address this workforce challenge? Adding more radiologists, adding more reading radiographers or technicians? What are the timelines to educate those people? And even more important, are there people available for those roles? As mentioned earlier, this example describes the situation for the UK, but many other countries in the EU face exactly the same challenge. 2 decades ago, many thought the answer to this problem would be use computer-aided detection for mammography. However, outside of the US, computer-aided detection didn't get that accepted in many of the radiology departments in Europe due to the higher recall rates and biasing the radiologist. Today, the answer from Chiron to this challenge is called MIA, Mammography Intelligent Assessment, and MIA is a CE market AI solution that is available for breast screening. MIA AI can help effectively to prioritize your studies in the worklist as a triage method, and MIA can also help as a full independent second reader in the screening program. Time to adopt MIA in a screening program is now, and I say now, because by doing so, your service will be ahead of time prepared for the extra workload. As per the model on the earlier slides, the screening numbers will remain under normal until around the September timeframe. After September, when the COVID restrictions are expected to be reduced and as the majority of the population will be vaccinated, the impact of the increased number of studies will become a reality. So how can MIA help into your existing workflow? Here in the illustration on the top, you see the typical double reader workflow as practiced in most of the breast screening programs today. In the box in the bottom left, MIA is used as a double reader triage workflow. In this configuration, MIA triages possible positive cases, ensuring they are prioritized for reading by both radiologists. In contrast, confident negative cases bypass this second reader. Any cases with conflicting results between MIA and the human reader will go to arbitration, just like they currently do. Using this workflow, MIA increases the efficiency up to 25%. Even greater productivity gains come when MIA is used as an independent reader. In this configuration, MIA replaces one of the 2 human readers. Disagreements between the human reader and Mia are managed through the usual arbitration process. Using this workflow, Mia increased the efficiency up to 45%. I'm now arriving at my last slide, and I want to thank you for your attention and time. Working for almost 10 years with passion in the breast screening domain, I feel that now is the time to grab the opportunity for change. With the challenges that many services are facing have been exacerbated by something as exceptional as COVID, it has made me feel that the answer should also be exceptional. Bring new technology that addresses the needs of today, and it's also a stepping stone to address the needs for the future. Thank you for listening, and I now hand over to Dr. Nisha Sharma.
Thank you. My name is Dr. Nisha Sharma, and I'm delighted to talk about case study evaluating Mia in breast screening. The UK breast screening programme is unique as it is a 3-yearly screening programme as opposed to many of the other screening programmes within Europe in which they are 2-yearly. We perform double reading as the gold standard, and the reading is performed by consultant radiologists, trained breast clinicians or radiographers. Arbitration of discordant cases will always take place, and this will either be by a single reader or by a group of readers to provide consensus. The UK model works very well, but it is labour intensive and will be a challenge to sustain in the future due to the ongoing workforce crisis. A recent census by the Royal College of Radiologists showed that 26% of breast radiologists are due to retire in the next 5 years. And so therefore the question is, can this high quality service be sustained in the future with the current challenges we pose? Now, the problem has been further complicated due to the pandemic, where there was a national lockdown within the UK on the 23rd of March 2020, and many of the routine services within the breast screenings programme were stopped. Now, there was no national announcement to stop breast screening within the UK, and therefore this was a local decision taken at trust level to stop breast screening. And by the end of March, all the breast screening units within the UK had stopped screening. We, however, continued to perform high-risk family history surveillance throughout the pandemic. Now, the impact for us within the Leeds Teaching Hospital, we stopped screening on the 24th of March and restarted at the end of July. And when we restarted, we initially invited those women who were invited but not screened, and then moved on to invite women who had had a delayed invitation to the screening programme. But also the programme was impacted because normally we provide 6-minute appointments for our ladies, so there's a high rapid turnaround. But due to personal protective equipment, we've had to change our appointment times, which initially was 6 minutes to 15 minutes, and now it's 10 minutes. So we've led to a reduction in capacity to 60%. We also found that women were less likely to attend due to their concerns about COVID-19, but when they saw the setup, they were reassured that we were delivering safety and patient-centred care. So currently, we used to have booked appointments where a lady would receive an appointment telling her what date and time her screening mammogram was, but due to the pandemic, we've moved to open appointments where a lady receives a letter saying that she's eligible for screening, and then she has to contact the unit to make her appointment. And this has had a heavy burden on the administrative team. And currently in Leeds, we have a backlog of just over 15,000 women who have still to be invited and screened. So the impact of the open invites are that in December, we sent out 2,303 invites, and 1,356 women attended, so our attendance had dropped to 58%. But for those that attended, our DNA rate was only 2%, which was reassuring. Now, this is a nice paper that was looking at the impact of COVID-19 on breast cancer diagnosis. And when they looked at the data suggested that the number of breast cancers diagnosed during the first half of 2020 was not as low as initially feared, and felt that the substantial proportion of the shortfall was due to the suspension of the routine screening programme. And when they looked at the actual numbers and compared January to June 2019 with January to June 2020, there was a 28% reduction in the referral for suspected breast cancer in the symptomatic service. And there was a 16% delay in those who received the first treatment for breast cancer diagnosis. So I'm now going to present a retrospective study that we performed looking at the impact of an artificial intelligence solution as a reader in a national breast screening programme. So this is the current model that we have within the breast screening programme. When a lady attends for a screening mammogram, this will then be read by 2 human readers. And if the 2 human readers agree, this is called consensus, they either agree that the mammogram is normal and the woman is put back to routine screening and will be invited again in 3 years' time, or the 2 readers agree that there is a mammographic abnormality and the lady will be recalled for second stage screening. When the first and second reader disagree, this is discordant read, and this means that we need a third human reader or a team of human readers to review the mammogram to decide, is the mammogram normal and they come back to routine screening, or is the mammogram abnormal and they need to attend for second stage screening. So in our study, there were 3 breast screening centres who provided anonymised mammograms from January 2012 to 2019 for this IRB approved study. Each centre employed double reading with arbitration of discordant opinions, either by a single human reader or a group of readers. And the original human reading opinions and outcomes assessments for the recall cases with pathology were obtained from the National Breast Screening Information System. The mammograms used in this study were a random sample from the entire dataset, which has not been used for algorithm development or training. The AI algorithm's opinion was paired with the opinion of the first human reader to simulate double reading, and sensitivity, specificity and discordant opinion rate were calculated. 40,588 mammograms were reviewed. All were read by 2 human readers, with 1,216 having a discordant opinion requiring arbitration. 40,230 had a normal outcome and 358 were biopsy-proven cancers. So the overall recall rate was 4% with a cancer detection rate of 8.5 per thousand. When the AI algorithm was applied as the second reader to this test set, there was consensus in 81.9% of the reads to either recall or not recall the cases. So this meant that 18.1% of the reads were discordant between the first reader and the AI algorithm. And this table shows the individual sensitivity, specificity, cancer detection rate and recall rate for the human reader one and the AI algorithm. But when combined in the double reading model, the human reader and the AI algorithm had a sensitivity of 95%, specificity of 96.9%, cancer detection rate of 8.4 per thousand, and recall rate of 4%. So the study showed using an AI algorithm to replace the second human reader would have allowed 81.9% of the women to obtain a definitive diagnosis of normal or abnormal, and only 18.1% of cases would need the input of an additional human reader, providing a feasible solution to combat the workforce crisis within breast imaging. So with the new model using artificial intelligence, the woman attend for a screening mammogram, and this time the mammogram, once acquired, would be read by the AI algorithm and 1 human reader. And where we have consensus, so both agree that either the mammogram is normal, so it goes back to routine screening, or if they agree the mammogram is abnormal and the lady's recalled for second stage screening. Where the algorithm and the human reader disagree, This would require human arbitration, either by a single read or a group of readers, to again decide if the mammogram is normal and goes back to routine screening, or abnormal and needs to be recalled for second stage screening. The study shows that an AI algorithm is a viable option to replace the second human reader in the double reading of screening mammograms. But the limitations of this study is that it was retrospective and there were small numbers. Current challenges within the breast screening programme in terms of sustainability and workforce crisis have been further complicated by the COVID-19 pandemic. And therefore we must maximise efficiency to ensure we can continue to deliver a high quality service, and this necessitates the need for artificial intelligence to support the double reading model. This will allow radiologists to support other aspects of the breast imaging service. And it's wonderful that NHSX AI has been awarded to Chiron to look at how MIA can be incorporated into the National Breast Screening Programme. Thank you.
So thank you very much to our presenters. Frans and Nisha have now joined me live for a brief roundtable discussion now. And then we'll have the Q&A session to follow. So just to make everybody aware, you can enter your questions into the Slido Q&A box. I see that there are a couple of already coming through, so please feel free to use that function. I'm going to start the discussion by posing the first question to you, Nisha. Nisha, in your trial at the Leeds Teaching Hospital, you evaluated Chiron's algorithm called MIA as an independent reader of mammograms, and you concluded that MIA is a viable option to replace the second human reader in the double reading model. I know that you shared some of your initial findings at RSNA this past December, and also congratulations again on being recognized by Aunt Minnie as one of the top 10 papers presented at RSNA 2020.
Thank you, Chris. I think, oh, sorry.
Well, I was just going to pose the question to you then on the back of that. So my question for you would be, how do you feel about AI now replacing one of the two human readers in a double reading model?
I would say that having done our study, I'm more optimistic. We know that double reading is the gold standard, that we do identify more cancers and it helps reduce the recall rate. But the problem that we have is that we do have a workforce crisis. And in 5 years' time, we're not going to be able to sustain this high quality service. So I'm quite excited at the fact that artificial intelligence may be able to help us do that. And I think that the retrospective study has shown that this could be a safe alternative where we can still deliver a high quality service, but also create efficiencies within the current struggling workforce.
Right. Thank you for that answer, Nisha. For our next question, can I turn to you, Frans? Frans, how do you think that breast cancer screening providers deploy AI at pace while at the same time maintaining patient safety, which we know is at the top of everyone's mind in terms of deploying this new technology?
Oh, Chris, yeah, that's indeed true. Patient safety should be at everybody's top list, and especially if you start deploying it in a real life environment. So patient safety is also key for our clinical solution, and actually it is at the heart of everything we do here at our company, at Chiron. But actually I would like to mention two things here. One with regard to the implementation. I will take that as the second part, but first of all, I think before we can step into a patient-safe deployment, together with the service providers in the different countries, it will require, in many countries in the UK as well in the EU, a policy change in the policy that will allow the providers to use regularly tested AI solutions that at least perform at the same level as the benchmark in their country. And we know that in many countries studies are going on and discussions are going on also to do so. If you look at the implementation, at Chiron we have introduced what we call a 4-phased implementation plan. And that plan is actually designed to ensure that the rollout is patient safe and that it is patient safety is put above pace in the enrolling of the solution. So in our first phase, we start with a retrospective evaluation of cases to validate that MIA is performing well against the population participating in the screening in the specific country or region that MIA is installed in. And once the optimal performance is achieved, we will use MIA as a shadow or silent reader. And MIA now looks at the prospective studies. At the end of this period, we look at the discordant cases together with the clinical leads in the region. The third phase in our deployment is to explain the role of MIA in the workflow to the wider radiology team and also gain their acceptance and their trust. Actually, it's a training on how we will use the AI live in the daily screening program. And finally, if this is all passed and successfully accepted, then MIA will be enrolled in the program as an independent reader. And this phased approach, as I mentioned, contributes to safe implementation and safe patient use.
Yeah. No, thank you. Those are that's a very interesting perspective, Franz. And I know that as organizations start looking at the increased number of studies that are coming forward to show what can be achieved in this space, I think that the approach towards implementation is really that next set of questions that organizations are thinking about. And I would say too, there's a lot of learning that that organizations can draw upon in terms of the way that they've introduced newly qualified readers into these kinds of systems. And I think some of the approaches that you're describing run somewhat in parallel. Obviously, a technology is different than a human being and bringing that in, but I think that there's a lot of learning that organizations are certainly sharing with us about how do we introduce a software solution like MIA and draw upon the learnings that we've gathered from those past experiences. So thank you for that understanding. Nisha, do you have anything else to add to what Franz is saying?
No, I mean, I think those are important points, but I think quality assurance plays an important role as well when we're deploying artificial intelligence. We already have that in place in terms for the human readers. We have our film reader report, we do performs, so we're constantly monitoring our performance. And I think as readers and as director of a screening program, what I would like to see in place are those measures when we're using the artificial intelligence algorithm. How will we have confidence that it's performing at the level that it should? And if it's beginning to decline in performance, how do we pick that up? So those are important issues and questions that do need answering before we can deploy artificial intelligence. Yeah.
No, thank you. Thank you very much, Nisha. I guess just to build on that too a little bit more from my perspective, I certainly think that what we need to focus on is helping radiologists really feel comfortable and confident in using the AI at this stage. Again, building on the studies and the evidence that's out there, but I think it's important that we reinforce to the community and that they feel confident that a solution like MIA, when MIA says to recall the woman or not to recall the woman, that they can trust that. I think that there are really two ways that this confidence is going to emerge. Clearly, the robust clinical evidence is what we're all after and what a lot of individuals and attendees at the conference this year are looking for. In breast cancer screening or in AI solutions across various different domains. I think the other thing too that will build the confidence is around minimal disruption to the existing workflow. And on that first point, I think evidence generation through clinical studies is key. And this needs to not just come through small reader studies on artificially enriched data sets, but as you've rightly pointed out too, Nisha, that this needs to really be built up on large-scale, non-enriched real-world retrospective studies that are truly representative of what a screening population looks like. This includes evaluating performance on various demographics, mammography hardware vendors, and cancer types. It also means that the performance is being measured against real-world screening metrics, which I think is something that your extended trial has been focusing on, really focusing on those endpoints like recall rate and cancer detection rate. There are, of course, calls for prospective studies, which are being positioned as really the next stage of evidence towards deploying AI safely. I guess that second point too around workflow, I think that is a real confidence builder, and it's about making AI practically invisible with no interference to existing workflows. And I think I speak for most breast screening readers that introducing any additional complexity or steps that could slow down the workflow or reduce clinical confidence will be rejected. And so that's a little bit more of how I'm summarizing some of the things that you've already presented. So I appreciate those perspectives. What I'd like to do is now switch to some audience questions, and it looks like some are starting to pop up into the Slido tool. So please keep the questions coming, and we're going to do our best to try and filter those and address the ones that we can now. And as I said, if we don't get to your question, we'll do our very best to try and respond to it after the session. Nisha, let me address the first question to you, if you may. We've got one question coming through asking, how commonly does the arbitrator in this double reading model remove true positive findings from the AI algorithm, and how do you deal with that?
So in the UK, we have a double reading model, human readers, and when we have discordance, we go to arbitration. And there has been an increasing drive for this to be consensus arbitration. So the decision is made not by one human reader, but by a group of human readers. And this has been largely successful in reducing the recall rate without negatively impacting on the cancer detection rate. But because we're humans, we will inevitably get it wrong. So we'll never have a 100% success rate. And I think this also applies when you start using artificial intelligence within the double reading setting. So when the algorithm and the human reader disagree, it would go for arbitration. And certainly, I think the best way would be for group human arbitration to review the case and decide if it needs to be recalled or not. And I think the majority of the time, they'll probably make the right decision and not recall inappropriate cases. But they will get it wrong. And we do get interval cancers within the breast screening program. That's inevitable. So I think when we start deploying artificial intelligence, we do that recognizing that it's the unit that's taking accountability for performance. And if we've agreed to use an artificial algorithm within our setup, then we're accountable for the performance of our unit as a whole and not as individuals.
Yeah. No, that's a very clear answer, and thank you for addressing that, Nisha. Let me address the next question to Franz, if I may. We've got one individual sort of asking about this goes on to the theme of confidence building that is going to lead to potential deployment and adoption. Franz, in your conversations and from your perspective, what should an organization consider when deciding which AI solution to deploy and potentially purchase?
Oh, that's a good one. So I think as an organization, it is important to consider, is the AI algorithm regularly tested? So we see a lot, and that's what of course was, if you compare it to the former use and introduction of computer-aided detection systems, often on small trials, enriched data sets and outcomes that were actually setting a scene and from an expectation management level raised the bar very high compared to what it delivered in the field. And nowadays, I think many organizations have the luxury to really look at AI algorithms that are tested regularly on large data sets with real data used, the cases used for testing the outcomes, so that you have a better estimation of how it will perform in your daily practice. That's one. And the second thing is work together with your supplier on a good acceptance inside the hospital. So start using AI is also gaining the heart and minds of the radiologists. It's a paradigm shift. It's like you're hiring a new colleague, as you just mentioned a few minutes earlier, Chris, in a reply. And we need to gain this trust from the Radiology Society that is working in a hospital, as well as from the people that are screened with AI, as if AI is one of the readers for an outcome. So it's an overall a data set of characteristics that really should be looked at once you, as an organization, start looking at implementing AI in your service.
No, thank you. Thank you for that, Franz. I think your reference actually to professional societies like the colleges that have the professional representation across Europe is a good place for me to segue into this next question. And this is for Dr. Sharma that's come through. If we now think of beyond even the professional societies now, Nisha, when you think about screening, particularly at a national level, now, how do we safely speed up adoption and deployment in large national screening programs in the UK or in other countries across Europe that have similar models where decisions are being made and guidelines are being created at a very national level for everyone to adhere to and comply to? And this question is sort of asking, it strikes me, says the attendee, that this could only move as fast as Public Health England if we think about the UK, and I'm sure that the other countries have similar kind of bodies that are making this potentially a slower process. It could take years. What is your thought on driving those discussions and seeing those changes happen?
I think evidence is really important. What we're asking is quite a significant change to the screening programme. And what we don't want to do is rush things without having the evidence in place. And therefore, what we need is cooperation to be able to deliver the studies that we need that will be able to answer the questions that people have. I think it's a challenge, but I think there's a huge appetite from Public Health England, from the professional groups, and from the radiologists themselves to explore the role of artificial intelligence. And one of the challenges really that we have, certainly within the UK, is the IT infrastructure. And that's been one of the limiting factors, which has certainly come to light due to the pandemic. And secondly, we're dealing with a breast screening information system that was created in 1988, and the plans are to update that so that we can become more compatible with innovative techniques. So I think there is a huge appetite, but I don't think we can rush this without the proper evidence, because what we want to do is create benefit and not harm for our women within our screening population.
Yeah. No, thank you. Thank you for that response. I'd like to ask this one of Franz as well. We've got a question coming in, and this is one that we commonly see at conferences like ECR. Based on some of the evidence that has been generated so far, friends, do you think we'll ever reach the point where AI is so accurate the radiologists won't be needed in screening? How do you answer that when you talk to potential interested customers?
Yeah, that's indeed a question, Chris, which you hear at ECR, which you hear at USOBI, which you hear at RSNA. Is AI actually replacing the radiologist? Personally, I think, and I think also many other companies like Chiron will say the answer is no. And I think it is no. I think the best outcomes are gathered AI in combination with a human, and that's also how our algorithm is designed. What I do believe is that the role of AI is becoming more important over the years. And right now, actually, if you look at the introduction of AI in general, I think if it would be an act in a theater, the curtains have just opened, and there's a lot more that can be done with AI. And once it's really introduced in a wider setting in the radiology world, we will learn answers to questions that we didn't ask ourselves before, and that will lead to better insights from both human and AI. And in that way, human and AI will constantly empower each other to get to better outcomes for at the end all the participants and patients out there.
Yeah. No, I've certainly been on the AI journey, as have many of you, I'm sure, attending this session, going back, 7 or 8 years since when it was really just starting to be socialized in these kind of conferences. And this question has been around since then. I certainly have the perspective now that there's a more common understanding of what the benefits of AI can be, and what the benefits of making sure that that it's used in an appropriate way with the human reader.
Yeah.
And each of both the human and the computer bring different benefits and different skill sets to the table, if you will. You know, the strategic thinking that is continuing to be done by the human reader, combined with the consistency and the performance of a computer algorithm that doesn't know that it's 4 o'clock in the afternoon and has had a busy day. That combining those kind of tools together with the radiologist really is there to help the human actually perform better and ultimately to give a better patient outcome. And I think that's that still continues to be my perspective on this, and I know it's shared by most of the enthusiasts in the clinical world who do want to adopt the solutions, but want to do it in a way that's going to be beneficial for them and for patients.
Yeah.
And I guess just on that note, Nisha, I do have an interesting question since I just talked about patients. This is again specific to breast cancer screening participants, but we've got one question here saying, how do you feel UK women are responding to the idea of having an AI algorithm read their mammogram? Is this a conversation that you and your colleagues are having, and what can you share in terms of what you've learned so far?
Yes, I think for the public, and particularly women who are attending breast screening, for them to have confidence in the artificial intelligence algorithm reading their mammogram, they have got to have confidence in the system, and that comes from us as radiologists. And we've got to believe in the technology and say that it's a good thing and support it, because if we say that, then the public will be reassured that we've got confidence. But what it requires is a cultural shift. It's a huge transformation to rethink the way that we're delivering healthcare. But that's not a bad thing. That's a good thing, because what we're embracing is innovation. And as long as we can ensure the ladies that we're delivering the same high quality service, that we're still going to have all the safety checks in place, and that they'll still get the best care possible that we're able to deliver, then I'm sure that they will embrace this. But it's about education and being transparent and involving them in the journey. So I think that's really important, that once we start taking these things seriously, start doing trials and studies, we do have to get patient involvement, because they need to understand what the ask is and what's the expectation. And just like we as radiologists, we have lots of questions and we have concerns, but we also understand that we can't continue the way that we are. So it's important that we do this journey together and we learn together, and we continue to do that, because once artificial intelligence is deployed, there will be continuing challenges, but we've got to face them together.
Yeah.
And I think one of the interesting opportunities that Chiron have in terms of working through the NHSX AI award that you mentioned in your presentation, Nisha, is that it really is bringing together a broad spectrum of national and regional and even local bodies to really try and look at all of these elements of evaluation, and that patient-centered approach and patient education component is really one of the key areas that's that will be evaluated as part of these pilot sites or these test sites as they get underway in the UK in the next couple of months, that incorporating that feedback from the patient and evaluating their confidence and understanding of the technology is going to be really key. And we're excited that has been put really at the heart of all of the evaluation. Franz, we've got a question I think that's geared more towards you, because this particular delegate is asking when MIA will become a product, like products from iCAD, ScreenPoint, or Genius AI from Hologic. And I'm sure you're excited to be able to share and reconfirm that MIA does have regulatory approval and is a product, but I'll let you kind of pick up on that and give a little bit more clarity.
No, actually, you just mentioned the right things, Chris. We are a CE. We have our CE mark. We finalized also recently another trial and maybe you can refer to that later on. EMEA is available for the market out there. So EMEA has the certification as an independent reader, but also for double reading triage, where EMEA can help the radiologist in organizing the work list for cases that need attention by two radiologists, or can be read by one other radiologist, but also as a concurrent reader. So MIA is there to be installed, I would say, and to be rolled out.
Thank you, Franz. I'm going to jump back into the clinical evidence side of things. There are a couple of questions coming through on that, and Nisha, I'd like to direct this one to you because we did touch on it very lightly in our kind of segue into the Q&A. But this person is asking if you could share your thoughts on prospective studies, and maybe even as part of that question, talk about how some of the national bodies are thinking around that too, in terms of further evidence generation.
I think prospective studies are important, and what we need to do is mirror sort of the real life processes that will be taking place if we were to deploy the artificial intelligence within the breast screening program. And currently the thoughts are that the algorithm would replace one of the human readers, certainly within the UK setting. So what you want to be able to do is deploy the algorithm and allow it to read the mammogram, and for that report to be available on the breast screening system. And then you have the human read, and then you can automate the process. So, and this is important because it will actually tell us in real life what are the challenges that we're facing, how is the algorithm performing, and what considerations do we need to think about? Because I think setting up a good prospective study will tell us, are we near deploying artificial intelligence in the clinical setting, or is there further nuances that have been raised and we need to do further work and create further trials to answer those questions? So I think these are exciting times, but I don't think we're far off in terms of deploying artificial intelligence within the screening setting, provided we get the right evidence and data. And also on that point, do you do a prospective study where you invite all different algorithms to come along so you can test them all in one go? Or do individual companies do their own trials? And that again is something that we do need to think about. We also need to make sure that the public's aware, we get informed consent, and that we've got processes in place to deal with any incidences as they arise.
Yeah, no, that's a very thoughtful answer, and I know it's one too that continues to be discussed at conferences like this, and it's a very exciting part of the conversations we're having with national programs. And Nisha, I'm going to stick with the theme of trial actually, and steer this one back to you as well. We've got another question really coming in around not only the trial and the study results that you were sharing, but I think we've certainly hinted at the fact that we've concluded a very large multinational and multi-center study, and you were heavily involved and acted as the chief investigator for that. This particular question is asking, in these studies, particularly the ones that we have conducted, did MIA find the same type of cancers as the reader? Were there any differences that popped up? And I think this is, again, kind of that next layer of the onion that the clinical community really wants to see, to be reassured that these algorithms can perform safely. What are your thoughts on that, and what can you actually share in terms of what we've seen so far?
Well, just to touch on that briefly, MIA did identify the similar cancers as the human reader, but also was able to identify some of the interval cancers that we as human readers missed. But this data will be published and will be available in more detail for our viewers to read with interest. And I don't really want to spoil that.
Oh, that's great. And Nisha has just kind of alluded on one of these questions here too, which I will use when I sum up. So we do have somebody asking about publishing our study results, and I will certainly signal that just towards the end of this session. So thanks for the little teaser there, Nisha. But I think that question that's being asked is really a very important one that the clinical community wants to see, and we have demonstrated very confidently that the different cancer subtypes that are of interest in identifying screening, including interval cancers, are being identified as well as, if not better than, the human reader in these kind of in our trials. So we'll certainly be excited to share that information. We're getting a little bit close to the end, but I do have kind of a technical question that has come through too that I'd like to direct to you, Franz. This is a question around integration. Everybody's trying to figure out if they bring these kinds of solutions into their department, how they will be integrated into their workflow. Can you give just a quick response to how MIA will be integrated? And maybe just following that too, if you could give some understanding and clarity about how that's being thought through for the National Screening Program in the UK, which we are integrating into.
So actually, if you look at how MIA is integrated, we integrate with, in the UK, it's integrating with the PACS and the NBSS, which is the back end of the system. And we use the standard integration keys for that. So that's the DICOM and HL7, and for NBSS is a special one which has been built. But for any other screening program, we make a connection to the PACS. We make a connection to the screening system if there, or the RIS or the HIS or whatever system is used to capture the patient or the demographic data from the patient as well as the results. And the images are actually processed in the cloud. So we prefer a cloud rollout that's easy. We can add the computing power that is needed to give a fast turnaround time so that women can have the result of their mammogram actually almost on the spot after being screened. So seamlessly integrated with the existing IT tools.
Right.
And
I think that's certainly what the CIOs of the organizations want to hear, and even the department chairs who are having to make these decisions across their departments. And so those kinds of deployment models, I think, have really been unlocked by COVID. And I think that's something that we've also seen, and the cloud providers have seen, that that we have to think about this in a different way. And it's not about bringing servers into hospital trusts and
not bringing servers anymore.
Bringing their algorithm through that model. That things are moving very quickly in that direction, and I guess that's one of the more positive outcomes that COVID has allowed us to test these kinds of technologies, because we've been forced to.
Yeah.
We have time for one last question, and this one's I'm going to go to you, Nisha. What would you say to the breast radiologist who fears their job is in jeopardy? And if you could focus your comments specifically towards those in breast cancer screening with the introduction of AI.
Well, what I would say is that we're irreplaceable as radiologists. So when artificial intelligence comes into play, what it will do, it will work alongside us and support us to be able to continue to deliver the high quality service. It will not replace us. We will be able to do tasks that are patient facing that will always require a radiologist to be present, but there are certain tasks which can be automated, such as film reading, where we can use the assistance of artificial intelligence, but we will never go to complete artificial intelligence reading of mammograms. So our jobs are safe, our role is important, and we're not irreplaceable. So I wouldn't worry about that. We're irreplaceable as a team of radiologists. And I think that's an important message that needs to be conveyed to the community, that artificial intelligence is there to support and create efficiency, but not replace us.
Yeah. Well, on that note, thank you very much, Nisha. And this does bring us to the end of our time together today. Thank you to our panelists, Franz van Beers and Dr. Nisha Sharma, and thanks to our audience for joining us today. We certainly invite you to visit the Chiron booth. We have a virtual booth at ECR, and we're waiting to talk to you via the live chat as well. You can also, and I know we've signaled that a couple of times in our discussion today, but you can also request a preprint publication of our recent multinational, multi-center, and multi-vendor clinical study. It's entitled Large Scale Evaluation of an AI System as an Independent Reader for Double Reading in Breast Cancer Screening. We would welcome your feedback on the findings, and thanks again for joining, and please do enjoy the rest of the ECR. And hopefully we see you all in person next year. Thank you.
Thank you.
Thank you, Chris. Thanks, Nisha.